to be awesome. So it's 27th of August to 1st of September next year, 2023, is going to be in Washington, D.C. It's going to be such a good meeting. So wait for a news soon. We are going to start the website and the social media of the World Congress. And I'm sure all of you are going to receive soon the latest news about it. Save the date. And we're going to have today, in a few hours, Dr. Mary Cohen talking about the fate of new aorta in congenital heart diseases, our ECHO series that she's restarted with us. This is going to be very nice. I hope all of you can join. And then we had this week, Dr. Silverman talking about hypoplastic left heart syndrome, the correlations of morphology and echo. It was very nice. I've learned a lot. So take a look on our YouTube channel to check this meeting and join us next month on his next talk. And now with all of you today, we are going to have Dr. Anderson with Diane, Adrian, and Justin to show amazing things for us. I'm sure all of you are going to learn. Please type all of your questions on the Q&A chat box. And if you like this session, please share with your colleagues the link of YouTube. Thank you very much for joining. Thank you, Dr. Anderson, and amazing panelists to be here with us today.
Well, good afternoon again to you, ladies and gentlemen. So this afternoon, we will complete our discussion of sequential segmental analysis. You will remember now that this will be our fourth session. In the first session, we discussed the whole notion of segments, and we established that thanks to the innovations provided by Dr. Van Praagh, we analyzed the heart in its 3 segments. And we discussed in the subsequent sessions how Dr. Van Praagh pointed out that in each of those segments there was limited variability, and because of that there were limited segmental connections. And in our last session we discussed the limitation of these connections at the atrioventricular junctions. But we pointed out that despite the limitation in the segmental combinations, the combinations of associated lesions was unlimited. And that is why we have to start off with sequential segmental analysis of all our patients. So as we have discussed, as in the concepts originally put forward by Dr. Van Praagh, we begin with the analysis of the segments. But what we have been emphasizing is that the shift from pure segmental analysis to sequential segmental analysis devolved on the analysis of the junctions, because it is the connections across those junctions that determines the way the blood goes round. And you will remember that in our last session, we discussed those variations at the atrioventricular junctions. So now, to complete our journey through sequential segmental analysis, we are going to look at the ventricular-arterial junctions. And so you will be well aware, in the normal heart, there are 2 such junctions. The emphasis of our discussion today is the need to discuss these junctions in terms of 3 parts. So the first part is the way that the trunks are supported by the ventricular mass. And as we discussed last week with regard to the atrioventricular junctions, we're going to call those the connections. Then we're going to look at the morphology of the outflow tract supporting the arterial trunks in fundibular morphology. And then we're going to emphasize the third feature, which is the relationship of the arterial trunks, not only as they leave the base of the ventricular mass, but also their relationships as they extend through the pericardial cavity to exit into the mediastinum. And the key we are going to emphasize is that these are independent features when the heart is congenitally malformed. But what about their relationship in the normal heart? Well, of course, the essence of normal arrangement is concordant ventricular-arterial connections. The aorta arises from the morphologically left ventricle. The pulmonary trunk is supported in its total amount by the morphologically right ventricle. And then in terms of relationships, in the normal situation, the aortic root is posterior and to the right. In the mirror image variant, which itself can be normal for the mirror image person, the aortic root is posterior and to the left. And that is also an important feature. The major feature we're going to emphasize, however, about normality is the spiraling of the arterial trunks. And then that reflects the fact in the normal heart, the pulmonary trunk is supported by a complete infundibulum, whereas in the normal left ventricle, there is fibrous continuity between the leaflets of the aortic and mitral valves. So let's look at that in this very nice arrangement of the normal heart that we made a long time ago by making casts of the morphologically left side, which you see in red, the morphologically right side, which you see in blue. And there you see the aorta, the centerpiece of the cardiac mass, emerging from the base of the left ventricle in right-sided and posterior position. Right-sided, despite the fact that in the normal heart, it emerges from the morphologically left ventricle. And there you see the pulmonary trunk in the normal heart, anterior and left-sided, with its root lifted away from the base of the ventricular mass by the completely muscular subpulmonary infundibulum. And then let me emphasize to you the third feature, the spiraling of the arterial trunks as they extend from the base of the heart into the mediastinum. And as I look at the spiraling from the front, in the normal heart, the pulmonary trunk is spiraling in counterclockwise fashion as it extends to the margins of the pericardial cavity. Now, this picture, of course, is made by making casts of the interior of the ventricular mass. What we're going to see now is what the walls of the ventricular mass and the arterial trunks look like in the normal situation. And as has been the case throughout these demonstrations, it's Diane who's going to show you the essence of the normal atrioventricular junctions.
We're looking at this normal heart in attitudinally appropriate fashion so that the diaphragmatic aspect would be along my probe. Here we see the morphologically right atrium and the arterial trunks as they are leaving the ventricular mass. This is the pulmonary trunk, which is located in an anterior and leftward position relative to the aorta, which is rightward and more posterior. You can appreciate how the arterial trunks are spiraling around one another as they leave the ventricular mass, with the right ventricular outflow tract wrapping around and anterior to the aortic root. When we look inside at the right ventricular outflow tract, you can see that the pulmonary valve is supported by a complete muscular infundibulum, and this muscular infundibulum will lift the pulmonary valve up off of the right ventricular mass. On the right, there is a true circumferential ventricular-arterial junction between the muscular infundibulum and the fibrocollagenous wall of the pulmonary trunk, so that each of the valvar sinuses and leaflets cross the ventricular-arterial junction with a small crescent of muscle incorporated into each of the ventricles. Now you might notice that there are a few little breaches beneath the pulmonary valve, and that's because I have superglued it back together because I removed the pulmonary valve to show the nature of the subpulmonary infundibulum and how it does lift the pulmonary valve up off of the right ventricular mass. And there you can see the extent of that subpulmonary muscular infundibulum relative to the aortic root, with the right coronary and the left coronary arteries exiting adjacent to the pulmonary trunk. If we look at the left ventricular outflow tract, we see the aortic valve, and it, like the pulmonary valve, consists of 3 semilunar leaflets. The aortic valve is supported by muscle in part, and the remaining portion is submitted by fibrous continuity between the aortic valvar leaflets and the anterior leaflet of the mitral valve. The membranous septum lies at the base of the interleaflet triangle between the right coronary aortic valvar sinus and the non-coronary or non-adjacent aortic valvar sinus. The mitral valve within the left ventricular outflow tract has some very thick fibrous connections that are known as the left and right fibrous trigones, and this right fibrous trigone along with the membranous septum form the central fibrous body within the left ventricular outflow tract. So that the aortic root has partial fibrous support and partial muscular support within the left ventricular outflow tract, unlike the pulmonary valve, which had complete muscular support within the right ventricular outflow tract. Here I have a special dissection of the arterial trunks as they leave the ventricular mass. So I've removed the front of the right ventricular free wall, a part of the pulmonary trunk, and the anterior aorta along with the right coronary aortic valvar sinus. So this is the right atrial wall with the transverse sinus between it and the ascending aorta. Here's the septal leaflet of the tricuspid valve, and our subpulmonary muscular infundibulum that is lifting the pulmonary trunk up off of the right ventricular mass. Also, you can see how the pulmonary valve lies in a more superior anterior and leftward position than does the aortic valve. This dissection shows us the subpulmonary muscular infundibulum lifting the pulmonary valve up off of the right ventricular mass, and as it joins the inner heart curvature, extending around towards the membranous septum. This is the caudal arm of the septomarginal trabeculation, and this is the medial papillary muscle. And here is the cephalic arm rising up to become part of the subpulmonary infundibulum. The important point here is that there is a fibrofatty tissue plane that extends between the right and left ventricular outflow tracts, so that there is no potential for an outlet septum in this region. Another important point to make is that the aortic valve is supported in part by fibrous tissue. There is the aortic to mitral valve fibrous continuity, and in part by muscle, so that I've removed the muscular support of the right coronary leaflet in this area, and there is a portion of muscle supporting part of the left coronary leaflet. This is the interventricular component of the membranous septum, and there is the atrioventricular component.
So there you are. You've seen the normal arrangement. And I've emphasized already the 3 components of normal anatomy at the ventricular-arterial junctions. So now we're going to look at the abnormal arrangements in the setting of this third part of sequential segmental analysis. And now we need to look separately at the features we have emphasized, the connections to start with, the relationships of the arterial trunks and the arterial roots, and the infundibular morphology. So here now we come again to that principle that we've been emphasizing throughout our recent discussions. And this, of course, is the morphological method, because here we have 3 different parts of the junctions to consider. So we have to decide which is the most constant component of those junctions in terms of the abnormal situations we're going to be discussing, because that is the essence of the morphological method. Namely, we should not use one feature which is itself variable to define another variable structure. And I'll remind you again, this key principle of the analysis of congenitally malformed hearts was again introduced by Richard van Praagh. I've told you this on several occasions. It was to criticize one of our own publications, and Dr. van Praagh was 100% right in that criticism. And so we have used the morphological method ever since. So how does the morphological method apply to the ventricular-arterial junctions? Well, it comes back again to determining which of the features we have been discussing is the most constant. And there is no question but that the most constant and the most important of those features is the connections between the ventricles and the arterial trunks. And it is the most important because it is the way the arterial trunks arise from the ventricular mass that is the final arbiter in determining how the blood enters the circulations. So we need to take particular note of the connections. But when we're looking at hearts with concordant ventricular-arterial connections, we accept that in concordant ventricular-arterial connections, the aorta is going to rise from morphologically left ventricle, the pulmonary trunk from the morphologically right ventricle. But we should then ask the question, do the arterial trunks always spiral? Well, the answer to this is no. But when the arterial trunks leave the heart in parallel rather than spiraling fashion, when they are concordantly connected, the hearts that have been described in this fashion have been bewilderingly complex. And it's the names used to describe them that have perhaps been the most complex. So a long time ago, when the aorta arose anteriorly and to the left from the morphologically left ventricle, it was called anatomically corrected transposition. It was suggested that that was an embryologic impossibility, but it was shown to exist, as I will show you, and then it was called anatomically corrected malposition. A variant on this is called isolated ventricular discordance, and yet another variant of that, when the ventricles are in their normal position, but the atrial chambers are mirror imaged, this is called isolated ventricular non-discordance. And then we have isolated infundibuloventricular discordance, and yet another complex malformation, isolated atrial discordance. Now, do all these names really help us? Well, this is taken from one of Dr. van Praagh's summaries of what's going on in subsets of given hearts. And there you see at the top, anatomically corrected malposition. He shows you variants for that with sequential descriptions. Underneath that, he's showing you so-called isolated ventricular discordance. And under that, the rarer variant of isolated infundibulo-arterial discordance. And you will note that one of those segmental sets is shown in dotted lines, and that is because as yet it has not been encountered. The feature of all these entities, however, is that the arterial trunks are parallel as they leave the ventricular mass. But then we have to take note of that other rare entity which Dr. van Praagh calls isolated atrial discordance. Now, the feature of this is that the arterial trunks are leaving the heart in spiraling fashion and they are concordantly connected. But that introduces another problem, because if we look at this variant, you see the morphologically right ventricle is on the left side, it's mirror imaged, and the arterial trunks are spiraling in mirror imaged fashion. And Dr. van Praagh has labeled this as I for inversion. But look here, here is another heart that Dr. Van Praag has labeled as having mirror-imaged arterial roots, and yet here the pulmonary trunk is arising from the right-sided right ventricle, and in fact is parallel to its arterial trunk. So this is a big problem to me. We will not have time to discuss this today, but we're going to devote one of our sessions to discuss the complex problems that exist in the relationship between all these segmental subsets. But let me show you, if I may, the majority of the cases that have parallel arterial trunks, parallel rather than spiraling. Because the variation that Dr. Van Praag focused on in all these combinations is a variation in infundibular morphology. But these rare entities do exist. This is the entity that was said to be an embryologic impossibility, but here you see it is for real. The arterial trunks are parallel. The aorta is anterior and left-sided. And when we open the left-sided ventricle, we see that it is morphologically left. And there it is, giving rise to this anterior and left-sided aorta. But the key here, the anterior and left-sided aorta, is supported by a completely muscular subaortic infundibulum. So for me, this is concordant ventricular-arterial connections with parallel arterial trunks. And so there, on the other side of the heart, you will recognize, I hope, the morphologically right ventricle. There is the pulmonary trunk, unlike the situation in the normal heart, where the pulmonary trunk is anterior and left-sided. In this heart, although arising from the morphologically right ventricle, the pulmonary trunk is posterior, right-sided, but still it is supported by a completely muscular infundibulum. And in fact, in this heart, there are also concordant atrioventricular connections. So the blood is going the right way round, despite the fact that we have an anterior and left-sided aorta. And here we have a muscular outlet ventricular septal defect. So we'll come back to these rare lesions and we'll discuss them along with those that were said to represent isolated atrial discordance in another session. But let us continue to discuss the problems of the ventricular-arterial junctions, because in those hearts with parallel arterial trunks, the infundibular morphology can vary, as can the relationships of the arterial roots. So we don't ignore that, we simply describe it. And that is what happens when we move on to look at the other ventricular-arterial connections. So you will all be well aware that although the majority of hearts that confront you, the individuals, have concordant ventricular-arterial connections, there is another specific subset in which the ventricular-arterial connections are discordant. And here is the first illustration of which we are aware of an individual having discordant ventricular-arterial connections. I've shown you this picture before. It's that from Matthew Bailey. And Matthew Bailey called it a singular anomaly. Nowadays, as you know, we call it transposition. And when we look at the evolution of thinking about transposition, again, we come across the three components of the ventricular-arterial junctions. And polemics have raged as to whether we should define transposition on the basis of the ventricular-arterial connections, or the arterial interrelationships, or indeed infundibular morphology. And for quite some time, it was held that the aorta could only be transposed when it was anterior and relative to the pulmonary trunk and supported by a completely muscular infundibulum. We now know that we can no longer abide by that because these features are mutually independent. So what do? We analyze each one separately. So we go back to the morphologic method, and we ask which is most significant. And again, it is the discordant ventricular-arterial connections, in which the aorta is now arising from the morphologically right ventricle, with the pulmonary trunk arising from the morphologically left ventricle. Why is that the most important? Because that makes the blood go round. So now Diane's going to show you a nice example of transposition.
This specimen has transposition with usual atrial arrangement, so that there is a morphologically right atrium to the right and a morphologically left atrium to the left. Looking at the arterial trunks, the aorta arises anterior and rightward relative to the pulmonary trunk. There are the brachiocephalic arteries branching from the aortic arch, and the arch extends to the left. This is the arterial duct. The aorta arises from the morphologically right ventricle, so we have discordant ventricular-arterial connections, and it is supported by a complete muscular infundibulum, so that this muscular sleeve will lift the aortic valve up off of the right ventricular mass. Here you can see the right coronary orifice and the left coronary orifice as they leave the aortic root and adjacent to the pulmonary trunk, or in the sinuses that lie adjacent to the pulmonary trunk. When we look at the pulmonary outflow tract from the left ventricle, again we have discordant ventriculo-arterial connections. The pulmonary valve has partial muscular support and partial fibrous support within the outflow tract of the left ventricle. The fibrous support between the anterior leaflet of the mitral valve and the pulmonary valve in this heart is actually quite narrow.
Well, having seen that very nice example of transposition that Diane showed you, in which the aorta was anterior and right-sided, we need to come back to the question which we posed on several occasions, because I'm sure that many of you who are listening to us and watching us today will consider L transposition as being a synonym for congenitally corrected transposition. I hope by now you're beginning to realize that it is not a synonym. And that is because left-sided and anterior aortas are the rule when regular transposition is found in the mirror imaged arrangement. And as you are going to see very shortly, we can also have anterior and left-sided aortas in the setting of regular transposition with usual atrial arrangement. But let me first show you a picture of transposition in the mirror imaged setting. So if you look at these atrial appendages, you will see that the triangular appendage with the broad junction, the pectinate muscles, pectinated wall extending to the crux is on the left side. The tubular appendage with a smooth vestibule confluent with the pulmonary venous component is on the right side. This is the heart of an individual with mirror imaged atrial arrangement. There is also mirror imagery of the ventricular mass. So the morphologically right ventricle is left-sided. There is left-handed ventricular topology. And when we have transposition in this setting, almost always, as you see here, we have an anterior and left-sided aorta. So this is L transposition. If we are going to take Van Praaghian terminology as it ought to be used, this is transposition ILL. And not only is it L transposition, it's also L loop transposition, but it is not congenitally corrected. And that is because L transposition is not the same thing as congenitally corrected transposition. And now Diane is going to show you how that is also the case when we have transposition SDL. Usual atrial arrangement, right-handed ventricular topology, but with a left-sided transposed aorta arising from the right-sided, morphologically right ventricle.
This specimen has transposition with concordant atrioventricular and discordant ventricular-arterial connections. We know that the arterial trunks can vary in their relationships as they exit the ventricular mass, and here we see the aorta anterior and leftward of the pulmonary trunk. This is the right coronary artery extending from the aortic root in front of the pulmonary trunk to reach the right atrioventricular groove. This ventricle has been windowed, so we need to tilt it upwards to look at the support of the aorta as it leaves the right ventricle, and it is supported by a complete muscular infundibulum. Looking at the pulmonary trunk as it leaves the morphologically left ventricle, we see that the pulmonary valve is in fibrous continuity with the anterior leaflet of the mitral valve and has both fibrous and muscular support as it leaves the left ventricle. And there is a small muscular ventricular septal defect in this case.
Now there's another variant in terms of transposition because we've got to look at infundibular morphology. And usually, since the pulmonary trunk is now arising from the left ventricle, we expect to find fibrous continuity in the roof of that left ventricle between the leaflets, the mitral, and now the pulmonary valve. But we do not always find that, and you will appreciate immediately that should there be bilateral infundibulums, it does not change the diagnosis of transposition because the diagnosis depends on the discordant ventricular-arterial connections. So now Diane is going to show you an example of transposition with bilateral infundibulums.
This specimen has transposition with usual atrial arrangement, so concordant atrioventricular connections and discordant ventriculo-arterial connections. The aorta is arising from the right ventricle, rightward, and almost directly anterior to the pulmonary trunk, which has a pulmonary artery band in this case. Here we can see the brachiocephalic arteries branching from the aortic arch. The aorta arises from the morphologically right ventricle and is supported by a complete muscular infundibulum. So here is the medial papillary muscle arising from the caudal arm of the septomarginal trabeculation, and there is the cephalic arm rising up to become part of that subaortic muscular infundibulum. Just to show you the variation of how the arterial roots can be supported within the ventricular outflow tracts, we see the pulmonary valve arising in discordant fashion from the morphologically left ventricle, and it is supported by a complete muscular infundibulum, so that this bar of muscle is interrupting the typical fibrous support that we would see, or fibrous continuity, between the anterior leaflet of the mitral valve and the pulmonary valve within the outflow tract of the left ventricle. So this particular specimen has bilateral subarterial muscular infundibulums in both the right and left ventricles. As you might have noticed, the specimen also has a mid-muscular ventricular septal defect.
Now, I have mentioned that over the years there have been huge polemics as to which feature we should use to diagnose transposition. And one of the biggest polemics devolved on whether, in the setting of transposition, there could be a usually related aorta with spiraling arterial trunks. And there's no question these entities can exist. They are very rare, but when found, there is also fibrous continuity between the leaflets of the aortic and mitral valves. We don't have an example to show you directly, but I can show you some pictures. So this is the first heart I encountered with what is known as posterior transposition. There is the aortic root. It is posterior and to the right. The cut tells you that it is arising from the right-sided, morphologically right ventricle. And on the other side, The left-sided morphologically left ventricle is giving rise to the pulmonary trunk, but the pulmonary trunk is now spiraling in normal fashion as it extends into the infundibulum. But the discordant ventricular-arterial connections establish that this is an example of transposition. This is another very interesting case, and this is from the Birmingham archive. And I hope that Adrian is going to be able to show you this in the discussion at the end of our session. What we have here is the morphologically right ventricle. You can see the tricuspid valve with its septal attachments. There is the aorta. We know it is the aorta because it's giving rise to the left coronary artery. There is a ventricular septal defect, and in the roof of the ventricular septal defect, there is fibrous continuity between the leaflets of the aortic and mitral valve. So, very rarely we can have transposition despite the fact the arterial trunks are normally related and there is fibrous continuity between the leaflets of the aortic and mitral valves. So that is transposition, discordant ventricular-arterial connections. Let's move on and let's look at the next ventricular-arterial connection. And that, of course, is double outlet. Nowadays, I'm pleased to say we have a pragmatic definition for double outlet ventricle, namely the groups of hearts in which the arterial trunks and the outflow tracts in their greater part are supported either by the morphologically right or the morphologically left ventricle. You will be well aware that the commonest variant is double outlet right ventricle, but the same rules apply when we diagnose double outlet left ventricle. In the past, for quite some time, it was argued that we had to have bilateral infundibulums to justify the diagnosis of double outlet. We know, however, that in many instances we can have double outlet right ventricle without bilateral infundibulums, and as you have now seen, bilateral infundibulums can be found in hearts with discordant ventricular-arterial connections. Also, I've shown you a nice example of bilateral infundibulums in a heart with concordant ventricular-arterial connections and parallel arterial trunks. Very rarely you can even find bilateral infundibulums in the setting of the otherwise normal heart. So now we know we no longer need bilateral infundibulums to diagnose double outlet right ventricle, and we shouldn't use that anyway because it's an abrogation of the morphological method. But what does arise now? So what we're going to look at first is a nice heart, nice hearts showing you these variations. So you've seen now that we no longer require the presence of bilateral infundibulums, but the point I was going to make just a few moments ago, there is another feature that now springs to our attention. Because what we do have to determine when we have double outlet is how we assign overriding arterial valves to one ventricle or the other ventricle. That also was very contentious in the past, but nowadays we have the means to do this with absolute accuracy because we can assess the short axis of the overriding arterial route relative to the chord subtended by the ventricular septum. And we see that most beautifully using computed tomography. I've shown you this picture before. It was provided to me quite some time ago now by my very good friend, Tony Lavacek, who practices at the Medical University of South Carolina in Charleston. And Tony produces the most exquisite pictures using computed tomography. Tony's been doing this now for more than 10 years. And now computed tomography is coming to the fore as the gold standard for showing us living cardiac anatomy. What Tony shows us here is that when we look down the short axis of the aortic root, we can relate it relative to the chord of the ventricular septum. And with total precision, we can see how much of the overriding arterial route is connected to the right ventricle, how much is connected to the left ventricle. And that permits us now with accuracy to say whether there are concordant or double outlet connections. So now Justin is going to join us again, I hope. He's going to be able to show us how, using computed tomography, we assess the commitment of the overriding arterial route relative to the cord subtended by the ventricular septum.
This is a neonate who underwent stenting of his arterial duct, and a CT was obtained for surgical planning in the setting of double outlet right ventricle. So this is a virtual dissection cut in a right anterior oblique view looking at the right atrium and the right ventricle. We can see a catheter coursing down the superior cable vein into the right atrium. We see a moderate size secundum atrial septal defect. Here's the tricuspid valve and then the tripartite right ventricle, the inlet, the apical trabecular, and then the outlet component. We can see the monitor band coursing and inserting into the base of the septal marginal trabeculation with its anterior cephalid and posterior caudal limbs, with the plane of the interventricular communication contained within the limbs of the septal marginal trabeculation. And if we draw a line from the crest of the ventricular septum to this structure, which is the outlet septum, that would represent the plane of the ventricular septal defect. And we can appreciate the relatively larger and anteriorly positioned pulmonary root with the posteriorly positioned and relatively smaller aortic root, with very minimal subaortic and subpulmonary infundibulum. However, the borders of the interventricular communication are completely muscular, formed by the crest of the ventricular septum. And we can see this intact posterior caudal limb of the septal marginal trabeculation, meaning that there is not fibrous continuity between the mitral and the tricuspid valve. So this is not perimembranous from a border standpoint. And then there's a thin layer of muscle underneath both arterial roots. But again, the ventricular septal defect plane being that between the crest of the ventricular septum to the outlet septum. The outlet septum is almost bisecting the interventricular communication with a slightly larger pathway from the left ventricle to the pulmonary root than from the left ventricle to the aortic root. So geographically, this interventricular septal communication being within the limbs of the septal marginal trabeculation is outlet, and from a border standpoint is muscular. So muscular outlet defect, which is slightly more committed to the pulmonary root. And so if we start to dissect this into a short axis plane, then this is how we judge how the arterial roots relate to the ventricles. So this is a surgeon's view. We're looking down into the left and the right ventricle. Here's the crest of the ventricular septum. And then we'll come back up to the arterial roots. So there's the larger pulmonary root and the smaller aortic root. And so I'll come back down so we can see that crest of the ventricular septum. So there's the crest. And then we'll come back up to the pulmonary root and we'll position it into a true short axis. So there is that crest of the ventricular septum seen inferior to the pulmonary root. And we can appreciate that the pulmonary root is approximately 70 to 80% committed to the right ventricle. And we can appreciate that the aortic root is 100% committed to the right ventricle. So this is double outlet right ventricle, regardless of the status of the subarterial infundibulums. And now we'll rotate, and you also can appreciate looking at the short axis that the pulmonary root is not only positioned anteriorly, but slightly leftward compared to the pulmonary root, looking in the surgeon's view. And now we'll rotate over looking at the left-sided structures. So here's the left atrium, the left ventricle, the mitral valve. We see the chordal apparatus and papillary muscles supporting the mitral valve. And then we'll dissect towards the right ventricle, looking so we can see the interventricular communication, the outlet septum, which is bisecting it. We'll dissect further going into the right ventricle to appreciate this larger pathway to superiorly to the outlet septum to the larger pulmonary root. So there's going into the right ventricle, seeing that larger pulmonary root, as opposed to the smaller inferior pathway to the aortic root. So this patient would do better baffling to the larger pulmonary route and then doing an arterial switch. And then just to finish up the anatomy, as I mentioned, this patient had a stent in the arterial duct. So we can see the dilated pulmonary trunk, and then the stent going through the arterial duct from the pulmonary trunk over to the thoracic aorta.
This specimen has a double outlet from the right ventricle with the aorta anterior and rightward relative to the pulmonary trunk. Looking inside of the morphologically right ventricle, here is our tricuspid valve inlet and both of the arterial trunks as they exit the right ventricle. Both arterial trunks are supported by complete muscular infundibulums, and both arise entirely from the right ventricle. The ventricular septal defect is remote or non-committed in this case, so it is an inlet defect lying beneath the septal leaflet of the tricuspid valve. This specimen has a double outlet right ventricle with the aorta anterior and rightward relative to the pulmonary trunk. If we tip the right ventricular mass upwards, here we see the aorta supported by a complete muscular infundibulum. This is our outlet septum, which is now a prominent right ventricular structure, and here's the tricuspid valve. The pulmonary artery arises in its greater part from the right ventricle, and there is a subpulmonary ventricular septal defect, this being the Taussig-Bing variant of double outlet right ventricle. Looking a little closer at the borders of the ventricular septal defect along the posterior inferior aspect, there is fibrous continuity between the tricuspid valve and the mitral valve, and as well at the roof of the defect there is fibrous continuity between the pulmonary valve and the mitral valve. This is better shown from the left ventricular aspect. Here is the anterior leaflet of the mitral valve, and there is one of the pulmonary valvular leaflets, and you can clearly see that there is fibrous continuity between the pulmonary valve, which is mostly committed to the right ventricle, and the mitral valve, so that there is no need for double outlet right ventricle to have bilateral infundibulums, and that you can have fibrous continuity between the mitral valve and the arterial valve.
So now we've seen 3 of the 4 possible ventricular-arterial connections. So what is the final connection? And of course, it is single outlet. But there are several opportunities for single outlet in the heart. Probably the commonest is when we have a common arterial trunk. In some instances, the pulmonary trunk can be sufficiently small to be very difficult to diagnose in the clinical setting, and then you might be called upon to describe a solitary aorta with pulmonary atresia. The counterpart of that is when it is the aortic root that is thread-like, and then you might need to diagnose the solitary pulmonary trunk with aortic atresia. But you'll appreciate that in many ways these are inappropriate terms because we would be recognizing the second arterial trunk. But there is one additional possibility we have to consider in the setting of single outlet, and when that is when there is truly a solitary arterial trunk. But let's start with common arterial trunk. And the definition of the common arterial trunk is now totally explicit. The trunk leaves the base of the heart through a common arterial valve. It supplies directly the systemic, the pulmonary, and the coronary circulations. And now Diane will show you the essence of common arterial trunk.
A common arterial trunk gives rise to arterial branches that supply the coronary circulation, the pulmonary circulation, and the systemic circulation. The first branches are the coronary arteries. There's the left coronary orifice there. and here is the right coronary orifice. The next branches are typically the pulmonary arteries, and in this case, we see the left and right pulmonary arteries arising in separate fashion from the common arterial trunk, whereas in other cases, a common pulmonary trunk can arise from the common trunk and then bifurcate to the left and right pulmonary arteries. The next branches arise from the arch, and they are the systemic arteries that will supply the systemic circulation.
So now I'm going to show you pictures of what on occasion might need to be called solitary trunk. In this instance, you can see we haven't got a solitary trunk. We have a big aorta, we have pulmonary atresia. And in this instance, we would not be diagnosing solitary aorta with pulmonary atresia because we would know that there were concordant ventricular-arterial connections with pulmonary atresia here in the setting of a ventricular septal defect, and indeed, this is tetralogy with pulmonary atresia. In similar fashion, we would not now be diagnosing this, in which we have pulmonary trunk with aortic atresia as a solitary pulmonary trunk, because we know that in this instance, again, we have concordant ventricular-arterial connections with aortic atresia. But on occasion, you can have problems in determining the origin of the atretic aortic trunk. So you may on occasion need to diagnose solitary pulmonary trunk with aortic atresia, but hardly ever is that the case. What we do have problems with, however, is this arrangement, because here there are no pulmonary arteries, no intrapericardial pulmonary arteries. And in the setting of absence of the intrapericardial pulmonary arteries, then truly we have a solitary arterial trunk. And why is that? The reason is because when the intrapericardial pulmonary arteries are absent, you have no way of knowing, had they been present, whether they would have arisen from the heart itself, in which case this would make the other trunk aorta, but they could have arisen from the trunk, making it a common trunk. So in the absence of the pulmonary arteries, the most explicit way of describing the arrangement is to account for a solitary arterial trunk, recognizing, of course, that the trunk is going to function as an aorta and is found in the setting most frequently of tetralogy with pulmonary atresia.
Cases with a solitary arterial trunk have no identifiable pulmonary trunk within the intrapericardial space. This aorta arises as the solitary arterial trunk from the ventricular mass. Here you can see the left coronary artery as it's been bisected, leaving the aortic root, and there is the right coronary orifice. The pulmonary arteries arise distally from the aorta, and here you can see where the right pulmonary artery arose from the base of the brachiocephalic trunk. The left pulmonary artery also arose from the aortic arch in a similar position to where we would see the arterial duct. The left lung has been removed in this particular case, and there are the left carotid and the left subclavian arteries.
So we've now finished our analysis of the ventricular-arterial junctions. And what I've stressed again and again is that we have to look separately at the three features of the ventricular-arterial junctions, namely connections, relationships of the arterial trunks, including their roots, and the infundibular morphology. And what I've tried to establish throughout our discussions of sequential segmental analysis is that it is connections that are most important, because it is the connections across the atrioventricular junctions, the ventricular-arterial junctions, that determines the way the blood goes around, remembering also that the venoatrial connections can be equally significant in this overall pattern of circulations. So what we now know is that an approach in this fashion lessens the potential for ambiguity and hopefully takes away those arguments that dominated the scene in the past. And hopefully we've also been able to show you that our approach of sequential segmental analysis is totally based on the initial segmental approach introduced by my very good friend Richard van Praag. And hopefully, as we move forward, we can take away the schism that seemingly developed between our systems, because in the final analysis, we're all trying to do the same thing.
So Grace, are you in charge now? I see we have Adrian lined up, and I know Adrian has some nice hearts to show us.
Yes,
So,
Adrian is going to show us some hearts, and after that, you're going to open for discussion with the panel. Adrian,
indeed,
please.
I'd just like to tell everybody that I'm here at the moment with Diane in Florida. I have Jim Quinticenza with me. And today, rather than the wintry London weather, we're enjoying the wonderful Florida sunshine. But Adrian is back in wintry Birmingham. Adrian, over to you, and show us the hearts that you have to emphasize the points we've been making today.
You. Can you hear me?
Yes, we can.
Perfect. So I'll just show 3 hearts. First of all, we start with this one. In attitudinally correct position, the heart will be situated like this. I'll just put in a surgical location with the patient lying down with the head here. So right hand of the patient will be here. And if we are looking at the heart, I'll let you look at the heart a bit. I'll just start pointing out that this is a morphologic right atrium. As you can see, inside the pectinate muscle goes all the way around. But there is no connection between this right atrium and another ventricular cavity. So I'll be brief in saying that this is a tricuspid atresia heart. If I turn, I can show here, this is the left atrium that goes into a left ventricle. This will be the mitral valve. I'm turning the heart again in a position that you would look as a surgeon. Remember, this would have been the attitudinally correct position. And from this left ventricle that you can see here clearly, considering the trabeculations in the apical segment being crisscrossed and fine, the great arterial trunk that comes off this ventricle is the aorta, and you see where the aorta is located. Now, if we are to look for the other arterial trunk, we can find it here. This is the pulmonary trunk. It's much smaller than the aorta that is here. These great arterial trunks are in parallel fashion. The right ventricle that gives rise to this pulmonary trunk is located anterior, superior, and to the left. So I'll orient you again. This is the right atrial appendage. This is the aorta. Pulmonary trunk is here. Here you can see the incised little morphologic right ventricle, which is located to the left, anterior and superior to the dominant left ventricle. So how would you call this heart in terms of the great arterial position, anatomically corrected malposition? It's best to describe where the great arteries are, and then we can look for the infundibulum. As you see here, there is aorta to mitral, aorta is here to mitral fibrous continuity. So again, a last view, this is the aorta, the dominant trunk, pulmonary trunk being parallel, located here behind it. A right ventricle is just the small, the rudimentary ventricle, anterior, superior to the left, and case of tricuspid atresia. I move forward to the second heart. And this would be the heart in anatomically correct position. I'll turn and I'll show now that this is a morphologic right atrium. As you can see here, the pectinate muscle disposition, it connects to a right morphologic right ventricle, then gives rise to this vessel, which is the aorta. And I'll come back to the coronaries. With the left aortic arch, you can see here the trachea. On the other side, I'm turning the heart. It's a morphologic left atrium that connects to a morphologic left ventricle that gives rise to the pulmonary trunk that you can see here. Now, it is a case of transposition, but let's look a bit further. What happens below the valves, the arterial valves? You can see that below the aorta, there is an infundibulum that separates the aortic valve from the tricuspid. And if I look on the other side, there is an infundibulum below the pulmonary valve separating it from the mitral valve. So bilateral infundibulums. But what is interesting about this heart is also the fact that it is a case of posterior transposition. Because look where the pulmonary trunk lies, look where the aorta lies in this case. The aorta is slightly posterior to the pulmonary trunk that is anterior. And one last bit I'll show you because it's beautifully seen how the coronary comes off the aorta. So this is the right atrium appendage, you recognize that. And I'm looking now at the circumflex that goes behind, from the aorta goes behind, this is the pulmonary trunk, and the circumflex goes behind this pulmonary trunk. The right pulmonary artery comes all the way and it turns in front of the aorta going into the right atrioventricular groove. And the last heart I wanted to show you, it's also an interesting heart that would highlight what Professor Anderson was saying about these different positions of the great arterial trunks when you have complex hearts. So in this heart, the right atrium, it's an operated heart, so you'll see the signs of operations. This is a morphologic right atrium that goes, so you can see the pectinate muscle, and that goes into a morphologic right ventricle, and that morphologic right ventricle gives rise to this vessel here. On the other side,
if I can interrupt you for just a moment, we have a fire alarm in Florida. So I'm afraid we have to leave. So I'm going to have to leave you and Norman and Grace to take care of the rest. We have to get out of the building.
Okay. So, look after yourself.
I'll leave it to you.
Look after yourself. We need you back.
We may be right back.
Okay. I'll continue with this. So, morphologic right atrium into the morphologic right ventricle. You can see here the sign of operation that was a VSD patch that was closed. I think they are back and unmuted. So the patch that you can see here was placed for the ventricular septal defect. Remember, morphologic right ventricle with the great arterial trunk coming off here. And then on the other side, this is a morphologic left atrium that connects to a morphologic left ventricle. You can see the patch again here, giving rise to this trunk. Now, there is, if I position the heart again in an attitudinally correct position, it will sit like this. The great arterial trunks are parallel. The aorta is anterior, as you've seen. There is a large midmuscular VSD. So how would you call this? An isolated ventricular inversion, an anatomically corrected ventricular malposition? It's indeed a very interesting heart. So again, this is the aorta. You can see a coronary coming off here and the other one on the other side. This is the pulmonary trunk that is located slightly posterior. They are parallel. The aorta is anterior and to the left, and there are concordant atrioventricular connections. Yeah. So in this case, I think it's best to describe the great arterial positions and not use these very complicated terms that I mentioned: isolated ventricular inversion, anatomically corrected ventricular malposition, or any other terms like this that are only confusing us. Just describe the connections and then describe the position of the great arteries in an attitudinally correct fashion. Thank you.
Very beautiful. Thank you, Adrian. Thank you very much.
We didn't have to leave, so we are still here.
We are happy that you guys are back. I'm going to start with Dr. Silverman with his always interesting comments. Norman, good morning.
Good morning, everybody. Bob, enjoying the weather, I see. I hope you're not playing too much golf. I think the interesting thing for me is I grew up in the Andersonian school, as it were. And so for me, many of these are not issues of importance. Where I've had problems in my life is when I talk to my colleagues who are Van Praguians. And I think that this is the problem. And much of your work has been, propagated through the communities. And so now we have people that, for their own purposes, use both terminologies and get into a lot of trouble. And if you ask many of my students about what detransposition is, they think detransposition relates to the position of the great vessels, which is in Van Praguian terms entirely wrong. And so from my point of view, one has to, and I think you've highlighted this quite clearly today, adopt either one or the other of the two terminologies. And I think the arguments that you've raised today show the actual rational basis of the Anderson method. And so that's really what I found the most important thing for not myself, but for the people that are listening to this, that perhaps are a little baffled by what the difference between the two terminologies might be. And I think that you've put that argument forward very clearly as to why the Andersonian method is the better method for looking at hearts in the future.
Well, thank you, Norman. Obviously, I agree with you. June, you've been through this, and you and I have also discussed this, and I know you have problems with so-called alignments, and you're very much in favor of connections. I mean, would you add anything to what Norman said?
Again, that here that should be described as connection. I do not have any question about it. Can I ask you the one question about the one information you presented to us? So you mentioned about in your slide solitary arterial trunk with aortic atresia. So if it is really the case, where are the coronary arteries arising?
So in fact, I tried to point out that I would not be using that, because as you've emphasized so clearly, if you have aortic atresia, the coronary arteries have to come from somewhere, and if they're rising from the aorta, then obviously that is not a solitary trunk. So I would not use the term in that. It has been used in that fashion, but I would not use that term. I did not make that clear enough. And you have emphasized that we should not use that term. The coronary arteries can't come from anywhere if there is no ascending aorta.
Yeah. Am I correct then if there is the solitary arterial trunk is always in the presence of pulmonary artery?
Correct. In absence of the intrapericardial pulmonary arteries, in fact.
Yeah. Okay.
And the point then is, and as Diane pointed out when she showed the heart, in essence, the trunk that you see arising from the ventricular mass is the aorta. And it's simply, for me, I cannot be sure. It's if you like, a term of absolute specificity. But to all intents and purposes, the trunk, as you say, is an aorta with pulmonary atresia.
Bob, may I make a point? We came across a specimen with aortic, not a specimen, a patient with aortic atresia, who also had an anomalous origin of the coronary artery from the pulmonary artery. I don't see any problem in that situation of defining what it was, but you know, when you see a bi-arterial connection of the coronary arteries, it on a classification basis creates a little difficulty.
But in that setting, Norman, the very fact that you knew it was aortic atresia, the point that June is making, had there not been another thing and the coronary arteries were rising as you described, it would have been a common arterial trunk.
With aortic atresia.
Well, no, obviously, but the very fact that you could find the atretic aorta, it was that point. June is making the point that if you can find the atretic ascending aorta, then it is not a common trunk, it is not a solitary trunk.
Well,
but as you say, in that setting, one coronary artery, presumably not both coronary arteries, were arising from the pulmonary trunk.
I've not seen that. So I think there's one other point I'd like to make of importance, and that's this question of the short axis view in double outlet right ventricle. And that doesn't create any problems for the person doing three-dimensional reconstructions, as Justin had shown us so beautifully. But for echocardiographers, it becomes a problem because there's lack of three-dimensionality in terms of making this connection. And so what the echocardiographer has to do is do a sweep from the great vessels through to the ventricular septum, noting the position of the ventricular septum relative to the valves in that situation. And that solves the problem.
Indeed. Q, you were going to make a point.
No, I was just going to make a point relative to the case you just mentioned, Norman, where the coronary comes off the pulmonary trunk, say, in a hydroblast with aortic atresia. Was that seen preoperatively and recognized?
Yes, yes.
Well, that's really good because a lot of times that's missed. And if, you know, the issue is when you do your aortopulmonary amalgamation during the Norwood, that coronary artery in the pulmonary trunk is perfectly fine. If it's not recognized and you excise the pulmonary trunk, it's usually a lethal mistake. So that's a very good pickup and a very important pickup in that rare case. So kudos.
Grace, do we have some questions that you would like us to answer?
We have a lot of questions this time. I think it's one of the topics that raise more discussion, and so it's going to be a very good. So let's start. So is there any association between abnormal coronary anatomy and infundibular malformation?
Not as far as I am aware. Diane, I don't think you're...
Not as far as I'm aware either.
No, I think the coronary arterial abnormalities are entirely independent of infundibular morphology.
So we have another question, and
in my opinion, the answering to that, there certainly is a strong tendency toward one pattern than the other, but it's not really very consistent. For instance,
you're right, June, that when but it's more typically side-by-side arteries rather than infundibular morphology, is it not?
That's true, yes. So, but the side-by-side has the really that due to really symmetric bilateral infundibulum usually. So that's what I mean, that there is great tendency towards some patterns.
But even then, you cannot predict the coronary arterial pattern based on the infundibular morphology. You are right, but it's more likely to have abnormal coronary arteries in that setting.
Okay, let's go to the next question. Why LTGA has more conduction issues than DTGA?
Say again.
Why LTGA is more associated?
The person asking the question has not taken on board the fact that LTGA is not congenitally corrected transposition. So please give us a break.
I think the person is actually thinking of congenitally corrected.
I think so, yes.
I just misspeaking.
It was
And that-
exactly what you
that
just said,
emphasizes
Norman.
the point that Norman has made, that
Exactly.
the people using LTGA are bastardizing the Van Praaghian approach to nomenclature, because Dr. Van Praagh would be talking about transposition SLL, not LTGA. But the question, of course, why, the answer to the question is that when you have congenitally corrected transposition, the essence of congenitally corrected transposition is discordant atrioventricular connections, which is what we discussed last week. And in that setting, you have an anomalous location. In 95% of cases, there is an anomalous atrioventricular node. But please do not use the D and L in that fashion. That should be the take-home message. The question emphasizes the take-home message from this session. D and L transposition should now be banned in the Congenital Heart Academy. Grace, you can be the thought policeman.
I'll try my best.
Do you want to mention the instance of the normalization of the conduction system with corrected transposition?
It's a good, Dr. Quinty Sensor is asking me that on occasion there can be a regular atrioventricular node in congenitally corrected transposition, but at the moment I do not know how frequent that is. I think that is something that we're going to have to, with what we're doing with Justin, we're beginning to look at to put the conduction system back into the heart with using computed tomography and histology, and that is one of the things we'll be looking at. We don't have an answer at the moment.
How about the rare instance of sinus inversus with congenital?
That also is the thing that produced the regular node there was pulmonary atresia or pulmonary stenosis. It's something else we're going to have to look into. Grace.
Okay. Is it possible to have difficult word in English, huh? The vessels in a spiral, but transposition. I think they meant without transposition.
I think it is possible to have spiraling trunks with transposition. Adrian, your case had spiraling trunks, did it not?
Yes, I have another case that actually shows the spiraling with a posterior transposition, not this one, because the pulmonary trunk is cut short. But yes, it is, and we have one.
Great.
But they are rare. They are very rare. And in fact, I made emphasis to the initial polemic, which was from 1971. The reason that I am in Florida at the moment is yesterday I gave the first lecture at the University of Florida in memory of Professor Van Meerop, who was a wonderful man, a wonderful anatomist. But in 1971, he and Dr. Van Praagh had a huge polemic as to what was the definition of transposition. And at that time, the key was that Dr. Van Praagh had found a patient with discordant ventricular-arterial connections with spiraling trunks. But in this instance, I'm afraid, Dr. Van Meerop lost the argument.
Okay, but just to stress that it's very rare, right? So still.
Oh, it's exceedingly rare. I think, Adrian, in Birmingham, we have 2 examples, do we not, of posterior transposition?
Yes, 2 examples, but only one with spiraling.
And in those examples, it is an autopsy case. I think in the Birmingham series now of 800 arterial switches, we have never seen a case with posterior transposition.
Indeed.
So very rare. Q, have you ever seen a case?
No.
I have a case in my app, and it comes from Houston, from Dr. Shane Morris. They've described this and published the case in abstract form, but there was no spiraling of the vessels in that situation either.
I saw a question popping up on the screen there, Grace. How do we distinguish transposition from double outlet? It speaks for itself. Transposition is discordant ventricular-arterial connections. It is no longer permissible to speak of an anterior aorta as representing transposition. Transposition is discordant ventricular-arterial connections. Double outlet is what it says, double outlet.
Okay, so there's another question about Towson B. Is asking, the image the doctor showed no pulmonary conus and there was mitral PA continuity. Is that lesion still be called Towson B?
It takes, this depends entirely on how you choose the definition. For me, that is a Towson-Bing malformation, because I see the Towson-Bing malformation as the transition with overriding of the pulmonary trunk between discordant ventricular-arterial connections and double outlet. So I have no problem in describing that as a Towson-Bing malformation, but those who insist on historical precedents would not call it that, because the initial Towson-Bing heart had a bilateral infundibulum. But I think we have to move on, we have to be pragmatic, and we have to know that just as there is a spectrum in tetralogy of Fallot, the tetralogy type of double outlet, from concordant to double outlet ventricular-arterial connections, so there is the second spectrum, the Towson-Bing spectrum, which has transposition at one end, discordant ventricular-arterial connections, and has double outlet with subpulmonary interventricular communication at the other end.
We have two questions about the same topic. What is the difference between solitary trunk and common arterial trunk?
The solitary trunk is absence of the intrapericardial pulmonary arteries. And in that essence, to all intents and purposes, the solitary trunk is the aorta. The common arterial trunk gives rise to all three components of the circulations: the coronary arteries, the pulmonary arteries, and, the coronary arteries, the systemic arteries, and the pulmonary arteries. So it's when there are no intrapericardial pulmonary arteries. It's the same topic that my aunt would have been my uncle had my aunt had testicles.
And there's another question still about this topic, asking about the other classifications, asking, will solitary trunks be type 3 of Van Praag classification and type 4 of Clayton-Edwards classification?
It is type 4 of the Collett and Edwards classification. Dr. Van Praag did not include the solitary trunk in his classification. In fact, I think the type 3, what is the type? I can't remember what, that's the problem with alphanumeric classifications. We can't remember them.
And there's one question from Tamara. Can you take double outlet right ventricle with VSD subaortic and transposition of the great arteries? And the physiology of this patient is tetralogy type.
That's a complicated question.
What is the question?
What is the question?
It's, I think she means that a double outlet right ventricle with transposition with subaortic
Well, you can't
VSD.
have double outlet right ventricle with transposition. This is the point. You can have double outlet right ventricle with anterior aorta, but you should not be calling it
Transposition.
This is the message that we should be taking home. Transposition is discordant ventricular-arterial connections. I think we all agree with that, do we?
Yes.
But
No,
I think on the question that she asked about physiology, if you don't have pulmonary stenosis, you won't have physiology of Fallot. You would have a physiology of a big VSD, probably.
Yes.
Norman?
Correct.
Correct.
Okay. When there is double totally muscular infundibulum, even in patients without transposition or double outlet right ventricle, is there always a dynamic subaortic obstruction?
No.
That's a very good question. I don't think you can be sure because, I mean, June, do you think that the muscular infundibulum is always dynamic and functioning?
I would say it depends. Yeah.
Go on, how does it depend?
Yeah. I think that frequently that dynamic obstruction we see, but not always.
So it depends in many ways on the diameter of the trunk, does it not? And I suppose it's more significant in the setting of a stenotic outflow tract? He's thinking. We can't answer that, Grace. Norman, do you have, Adrian, do you
Well,
have
I think
thoughts on
that we've seen examples of muscular infundibulum, left ventricular muscular infundibulum, where there's no obstruction. I think that's kind of common. The interesting thing is that in the condition that, if I don't offend Jane Somerville, membranous subaortic stenosis, there's frequently a muscular infundibulum. In that case, the obstruction is usually rather membranous than it is muscular.
Adrian, do you have thoughts on that?
I think sometimes it may depend, as you said, on the circumference of the great arteries, but also if there is any malalignment, I think, below the great arteries of the septum.
I see that someone's coming back there, Grace, but she has still not given away with transposition. Malposition should also be, we don't need malposition anymore. We simply describe the relationships.
Well, as far as the infundibulum, we've seen some cases that can be circumferential and bilateral that are very thin muscle bars, and those
Correct.
potentially would not cause an
Absolutely.
obstruction, as opposed to the very thick bulbous ones.
I think, as June says, it depends on the extent of the infundibulum. It's a potential obstructive entity, but you'd have to look at it in greater detail. We discussed in a previous week that it can be very difficult to distinguish. You made that point, June, did you not? It can be very difficult to distinguish extensive fibrous separation from a thin layer of muscular separation, myocardial separation.
We have.
Go on, Grace.
It's
I think we
impossible
should.
echocardiographically to do that, though, Bob. And that's one of the problems in this mitral aortic fibrous continuity issue, is that it depends on the technique that you have. And ultrasound cannot distinguish really fibrous tissue from muscular tissue in the subaortic region.
Indeed. I think you stand more chance with computed tomography, do you not, June?
June?
Talking about it, there was a comment in the chat that I want to raise here and listen your idea about it. It's a pity that Justin was not able to join today. So the comment is that tomography gives better real-time picture than empty morbid specimens.
Absolutely. Without question. I think that now the dissection of computed tomographic images is the new gold standard. I think without question, you do not have to open the heart, so you don't distort. I mean, having said that, the pictures that you've seen today with Diane's presentations, we've been commenting here in Florida. Dr. Quinticenza was able to give Diane the opportunity to make all these wonderful videos, and he and I are amazed at what she produces. But in order to show what's inside the heart, you have to open it.
True.
And of necessity, then, you introduce a degree of distortion. So I think that the ability to show the anatomy with computed tomography, with not distorting the relationships of the intercardiac structures, I think that is the new gold standard. I mean, June has been doing this. June has been making casts. You know what, June, you've been doing this for a long time.
I think that Justin showed that very well today. So what it is, the advantage of imaging, I don't think that the imaging can be any better for the detail, as compared to specimen, no question about it. However, the imaging has something unique feature. What it is that sometimes if you look at it, you want to see that whole thing, but sometimes you want to section it. So in specimen, you can't do it both, right? If you section it, you destroy it. So that's why you don't do it. But however, in an imaging, And then if you want to look at the volume, you can see it. If you want to section it and see it, you have everything in your hands. That is why that the imaging is so strong. And then what Professor Anderson showed, this is the way to go, showing that short axis and then seeing the ventricular septal crest. Absolutely. For instance, that is you can scroll up and down all the way in a different angle. That's how that you can be far, far more consistent and accurate. But however, I want to make the correction there. It is better not to describe that as a short axis, but usually short axis, the short axis to the ventricle is similar, but what you showed is a short axis of the aorta, okay, or pulmonary trunk. And then actually that is the probably proper term could be down the barrel.
Yeah.
Yes. So, and then is because that some people can be confused that what short axis means, because short axis is usually the ventricular short axis. Yeah.
Indeed.
Now,
just for a second, just back to the question of the specimens versus computed tomography. I mean, both give a level of understanding which are both the same and actually different. From a surgical standpoint, three-dimensional imaging gives us these relationships between, within or around the different structures. But when we think about, like, when we look at the specimens that Diane showed today, looking at the septal structures and kind of imagining where we would make an incision for, say, a Kono procedure, or excising a pulmonary autograft, when we're doing a Ross procedure. I mean, I don't think you can get better than seeing the actual specimen to then know what you'll be finding when you actually do the operation. So I can just say from a clinical standpoint, I think all these modalities have their place, and they're actually all, to me, synergistic.
And I think the point you make, Q, is very important there, because we had another comment that flipped up on the screen that, to me, I've been doing cardiac anatomy throughout my career, and it's second nature to me. So when I see the computed tomograms, I understand instantly that in the context of cardiac anatomy. But if you don't know cardiac anatomy, then the computed tomograms themselves can be a little difficult. So I think you're right. You have to have the two, you have to meld them together. But I think that now, with the ability to do that, to add the additional three-dimensionality that you get with computed tomography, that is what is going to take us forward.
Sure, I just want to make one little point.
Okay, go ahead.
I want to make one little point of importance here, is when we're talking about three-dimensional tomography, we also have to include three-dimensional echocardiography, because although it has certain deficiencies, it has certain advantages. And certainly looking at atrioventricular valves in their real motion, or the semilunar valves, that technique is without parallel. So the thing is, we've got a number of modalities now that we can look at these things, these phenomena with, and we can use the particular advantage of the particular tomographic method for defining what we really need to know in real dynamic terms.
Completely surrender.
I just wanted to support what Dr. Kidescenza says, and not define gold standards between morphology and imaging. I think the great majority of doctors do not have access to the specimens, and you can shortcut your understanding to the CT if you have access to the specimens.
I agree with you. I think you have to build from the knowledge, and it is still the knowledge of the specimens that will give you the basic understanding, and particularly when we see, I think Diane's demonstrations today were truly spectacular.
And the new
can I ask you one question?
Really convert to data sets, Norman, as you were suggesting, where you bring echo data and superimpose it on the CT data. to really get probably the highest resolution of all the structures, not just the muscular components, but the chordae, the valve structures. I mean, that convergence of those two data sets probably has a real chance of showing that all very well. Which current technology is kind of getting to. I don't know that we have it right at hand yet. It's coming.
Grace, I noticed there was a comment from my good friend Laszlo Kirai, who is in the Gulf somewhere with you, is he not?
Yes, he's saying that specimens and 3D printed prototypes also give hepatic information. CT echo exists in the virtual reality. That's what we are saying. I think it's going to be a combination of all modalities for the better understanding. And something that Adrian just said, that maybe is going to be the future. He's right, not every program has access to so many specimens with different cardiac anomalies. So maybe what is going to be done in the future is to get all these amazing CTs and do 3D printing and have like a data set, a bank of 3D printed, so you have both worlds. What we have on the CT, not empty heart, and with the relation with the other things in a printed, where you can look and see in your hands the 3D. And maybe virtual reality will get used to that, to understand the virtual reality as a real 3D thing. Our brain.
Well, I know that,
can I make a comment about that? We have started doing this at the University of California in San Francisco, that we have taken the specimens, reconstituted them with the crazy glue, etc., dumped them in iodine, alcohol solution of iodine, left them for a long period of time in the iodine, and then taken them to the micro CT array and scanned them. And so that we have now a series of three-dimensional images in a data set that we can look at with the computerized tomography and cut them in any way, shape, or form, just as you can. And I think that's been very exciting. It's not a complete study, but it certainly will be when we've done a number of specimens to make this analysis of a dynamic relationship of a closed heart with three-dimensional tomography. So, and that, of course, that data set is then available for anybody. All you need is a program to do the analysis, and you can dice and slice it any way you want. So I think in the future, these libraries will be something like the Carnegie collection, which will be available for everybody to look at. And there obviously won't be any arguments about what the connections and the relations will be.
And what you say is true, Norman. And in fact, when you, with the iodine enhancement, and Adrian is also in the process of moving along that line, you can see the conduction system with much better. More than that, you can see the aggregation of the cardiomyocytes within the ventricular walls, and you can ascertain how that varies. And Adrian, I don't know how progressed we are. We were going to do that for hypoplastic left heart, were we not?
Yes, and it's coming, and I think that kind of imaging is a completely different level, because you can't achieve that with the clinical grade imaging that we have today. But that gives you histologic granularity, and we will be able to say much more than what we can say, obviously, with the naked eye or with the clinical imaging.
And the point was made about making libraries. June, you prepared a wonderful series of libraries from your reconstructed casts. You had about 40 that you made a little booklet of them. Have you made that? Is that what has happened to that? Is that June?
That's a question for you. Can you unmute yourself and talk?
Excuse me.
June, you made that lovely series of, and you made your booklet of the double outlets. You showed the various types. Did that, is that still available?
Yeah. Actually that continuing increasing the numbers of cases. Yes. And then I have the case series that open to our website, and then anybody can take this.
And are they now on the website?
Yeah.
So already you are creating a virtual resource of the reconstructed.
So you know that there is a joke, and then I wrote a book, and then I find that here the kind of loyalty to sometimes the $100 a year. And then why that do I need to give this all information to the publisher, getting $100? I just decided to release everything free to everyone.
Absolutely.
Oh my God, Norma, this is so cute. What's its name?
Oh, so I have one question to Diane and the Bob, and I really looked at the one slide with the video clip with the really great interest. What it is that you mentioned about the subpulmonary freestanding infundibulum. And then in one cut, you show that the fat plane goes all the way down to the normally we describe as outlet septum, almost reaching the area of medial papillary muscle of Lancisi. And that is really fascinating to me. Why? That is very close similarity to your limbus of fossa ovalis or secundum, the part of the septum, and then the epicardial fat invaginates into there. So, and then that here, Bob, you insist that that is not the atrial septum type of things. So, and I really didn't realize that the fat can invade all the way down to there. And then question is that the area we usually describe, crater between the anterocephalic and posterochoral limbs of fossa ovalis, the trabecular septum marginalis, and then that crescentic area, really the septum. Or is it really the actually freestanding subpulmonary infundibulum?
Correct. And we have realized that what we thought was outlet septum is not outlet septum. There is no outlet septum in the normal heart.
Yeah, you mentioned once, but I really realized that that specimen shows that infundibular septum behind what we usually say outlet septum, there is really fat coming down.
Correct. It's really the infundibular sleeve, and we're working on something along those lines at the moment. And I think there again, the virtual dissections will confirm the dissection that Diane showed today.
June, people are asking the name of the website. They got interested on
Oh,
that.
it's easy. www.3dprintheart.ca. 3D print heart with one single word, .ca.
3D print heart?
Yes, 3D print heart.ca. So we want you to have .com, but somebody created it, and then they asked us the $20,000 to buy it. So it's the 3D print heart.ca.
There it is up on the screen. Grace has done it already.
So guys, I think we have to stop here. It's almost 2 hours. It was an amazing session. Please, guys, share this video with your team. I'm sure everybody's going to learn a lot. We could see that is a topic that people still have a lot of doubts, a lot of confusion. So it was a very clear presentation. This is going to be very helpful to everybody. And thank you to you all.
Just before we leave, let's remind everybody that you made the request that for our next session, we should consider the conduction system. So we will have a review of the conduction system in 2 weeks' time. And then we will be thinking where to go from there. But in 2 weeks' time, we will have, again, I will still be in Florida at that time. So we will have 2 weeks the conduction system.
So please join us in 2 weeks. I think it's going to be very important. Something that we noticed that absolutely every meeting, we have 1 or 2 questions about the conduction system. So we're going to have one session only dedicated to that. So please invite your team. So I'm sure this is going to be a very helpful session for everybody. Thank you very much, guys. It was really amazing.
Great.
Bye.
Thank you.
Bye. See you soon. And who's interested in echo, we have in a few hours Dr. Mary Cohen and her series of echo. Please join us today. Bye bye, guys.
Bye bye.